Start.
Developmental dysplasia of the hip DDH. More common in females 6:1. Most common in left hip. Intrauterine position being left occiput anterior. Left hip is adducted against the mother's lumbosacral spine. Family history: oligohydramnios, macrosomia, limited hip abduction, talipes, swaddling. Types: dysplasia, subluxation, formation of a ridge of thickened articular cartilage called the limbus. Dislocation, delayed ossification of the femoral head is seen in cases of dislocation. Pulvinar thickness, ligamentum teres thickens and elongates, transverse acetabular ligament. Hypertrophies, hip capsule and iliopsoas from hourgass configuration. Teratologic hip, dislocated in utero and irreducible on neonatal exam. Presents with a pseudoacetabular associated with neuromuscular conditions and genetic disorders commonly seen in arthrogrypsosis. Myelomeningocele Larsen's syndrome, Ehlers-Danlos, late adolescent dysplasia. Physical exam less than 3 months. Mainstay of physical diagnosis is palpable hip subluxation and dislocation of exam. Barlow, click of exit, dislocates a dislocatable hip by adduction and depression of the flexed femur. Ortolani, click of entry, reduces a dislocated hip by elevation and abduction of the flexed femur. Gallici Ellis, apparent limb length discrepancy due to a unilateral dislocated hip with hip flexed at 90 degrees and feet on the table. Femur appears shortened on dislocated side. Physical exam greater than 3 months to 1 year. Limitations in hip abduction, length, leg length discrepancy predominates. Clesic test used to detect bilateral dislocations line from the long finger placed over the greater trochanter and the exit finger over the ASIS should point to the umbilicus. If the hip is dislocated, the line will point halfway between the umbilicus and pubis. Physical exam greater than 1 year walking child, pelvic obliquity, lumbar lordosis irresponsible to hip contractures resulting from bilateral dislocations in a child of walking age. Trendelenburg's gait results from abductor insufficiency. Leg length discrepancy, toe walking, attempt to compensate for the relative shortening of the affected. Treatment less than 6 months old and reducible hip abduction, splinting, bracing. Pavlik harness 6 to 8 months old, failure of Pavlik treatment, closed reduction and spica casting indications. Open reduction and spica casting indications. Greater than 18 months old, failure of closed reduction, open reduction. Femoral osteotomy. Greater than 2 years old with residual hip dysplasia, anatomic changes on femoral side. Example: femoral anteversion, coxa valga. Best in younger children less than 4 years old. After 4 years old, pelvic osteotomies are utilized. Femoral varus derotational osteotomy, open reduction in pelvic osteotomy indications. Greater than 2 years old with residual hip dysplasia. Severe dysplasia accompanied by significant radiographic changes on the acetabular side. Increased acetabular index. Used more commonly in older children greater than 4 years. Decreased potential for acetabular remodeling as child ages.